in today's rapidly evolving field of anesthesiology. It's not anymore a choice. With the expanding role of ultrasound in regional anesthesia and intervention pain, mastering these skills is an important part of your contemporary anesthesia practice. In IAPM, we bring you a meticulously designed academic program featuring some of the most experienced experts and trainers in this field. Today, we have the privilege of learning from a true master and a trainer in ultrasound guided procedure. It's my proud privilege to introduce Dr. Madhan Pandian, sir. He is my senior from Madurai Medical College. He is a clinician from Pondicherry, teacher, expert in ultrasound guided intervention, and he is certified both by RMSK and CIPS. I'm sure his expertise, experience, and practical insight will make today's session highly informative and enriching for all of us. Dr. Madan Pandya, sir, we are delighted to have you with us. Welcome and over to you, sir. Please.
Right, sir. Thanks for the introduction, sir. So right away we'll move into the lecture because it's a bit too late actually. Could you see my slide?
Sir.
Okay. Is it moving, sir?
Yes, sir, it's moving.
Right, sir. Right, sir. So we will just go ahead with the lecture today. I have actually designed my lecture focusing only on the elbow. I have deliberately avoided wrist and the shoulder interventions. I think most of you would have heard from me. So such a very small topic seemingly, but needs a lot of discussion. You would be wondering, like I'm just going to take an entire session on elbow, which contains some 76 slides, right? So we'll just quickly go through all the things. We'll discuss about the sonoanatomy, the pathology, and the interventions associated with elbow. The scope of the discussion will be to discuss on the anatomy, sonoanatomy, which is pertinent to pain specialists, interventionists, and sports medicine practitioners, nerve entrapments, and the ligaments around the elbow. These are my references, quite a lot of these references. The most important one, I always insist people to read, means like all the interventionists, to read the last article, European Journal of Radiology, which is in 2015, which gives a detailed assessment of the ligaments, tendons, and nerves. Please note it down. This particular article, if you read actually, most of the interventions and the anatomy, the sonoanatomy, you'll be able to make. European Journal of Radiology 2015. So why ultrasound? All of us know that ultrasound is always mandatory in musculoskeletal conditions because it provides a lot of information on dynamic examination. It provides information on the integrity and the contiguity of the tendons and the ligaments. You can use color Doppler to identify tendinopathies, and obviously it is operator dependent. Not every time the same finding from different interventionists can be interpreted differently, right? How important is elbow? Very, very important because this is one of the most neglected ones. And clinical examination followed by sono examination. Unless you do a proper clinical examination, you probably may not end up doing a good sono examination because it's very difficult to do a focused examination. If you can do a proper clinical examination, you can focus on that particular structure which you want to really examine. You can actually do a yeah. You can actually do a protocol-based examination by the ESSR protocol or a dynamic examination and a stress protocol. The valgus and the varus stress protocol also can be followed. You can actually have something like this, the office-based protocol, which is a soft protocol, anterior, lateral, posterior, and the medial side examination of the elbow. Anteriorly, what all you can see here on the elbow, right? You can see these structures anteriorly if you keep it. You can see the cartilage here, the humeral cartilage, the brachialis muscle. You can see the long head of the biceps, the brachial artery, and then close by you have the median nerve. There are so many muscles, a few tendons, and a few vessels, right? You need to identify all the muscles, tendons, and the vessels. The brachial artery close by you have the median nerve, the brachialis muscle and the tendon associated with it, the brachioradialis muscle, and obviously the long head of the biceps. And there is an important structure which you need to understand, that there is a Lacetus fibrosis or the bicipital aponeurosis, which is going above the biceps tendon. And if there is an injury to the biceps tendon, naturally this lacetus fibrosis is likely to get injured. There is a discontinuity of this fibers, then likely that you are actually having a distal biceps tendon injury. Normally, how does it actually look like? Normally, the distal biceps looks like this. It actually looks like a bifascicular insertion, the long head more proximal insertion than the short head of the biceps. You can see the two heads getting inserted onto the radial tuberosity. Now, you need to understand there is an obliquity of the insertion of the long head of the biceps onto the radial tuberosity. So most of the times you'll not be able to see the two fascicles unless you have a proper oblique positioning of the uh, linear transducer. The mode of injury, again, it could be a forced extension against the resistance or an elbow in a mid flexion. There could be a Popeye appearance if at all there is an injury to the muscle. Otherwise, there could be a radial head related pain if there is only a tendon injury. Clinically, there could be a soft palpable defect or a small soft tissue mass. On ultrasound examination, you could identify if it is a chronic or an acute tear, complete or a retracted tear. So this is how exactly a Popeye looks like. Exactly when you do a proper flexion, this is how it looks like. A big pop eye, it just pops up when the patient does a proper flexion. And these are the ways you look for the distal biceps. The most common way, which I always advise you to go for, is a oblique anteromedial view through the pronator window. The lateral approach through the coronal plane along the lateral aspect of the radius, and a transverse approach with the cobra position. So all these are very essential to identify if there is any distal biceps injury. Right? This is how a oblique anteromedial approach, you can see through the pronator window, you can see the insertion of the long head of the biceps. So this is by far the most common one. The lateral approach, again, you can see the supinator over the radius and below which you can see the long head of the biceps. Again, this is not the true insertion point of the long head of the biceps. If you really look for the integrity of the long head of the biceps, you can actually do a proper dynamic maneuver. You can do a flexion. You can do a proper flexion of the elbow. Then you can see if there is any disintegrity of the tendon. Right? This is how the tendon looks like. See, this is the biceps. This is the biceps here. You can see the supinator, the two heads of the supinator, and this is the radius. You can do a flexion at the elbow, and you can see the look for the integrity of the long head of the biceps. Right? If you do a proper cobra examination like this, you can see the insertion. That's the right insertion of the distal biceps onto the radial tuberosity. So, what are the conditions which are possible there? The distal biceps tendinopathy, it could be a tear. There is an enthesopathy, which is more common than a tear. And the function of lacetus fibrosis, I think, like we will not go too much into the physiological part of the things. So it supports elbow flexion and stabilizes the distal biceps tendon and reduces the stress of the enthesis. It could be a complete, partial, or acute or a chronic tear. It could be associated with an avulsion fracture of the radial head. So this is how it looks like, the lacetus fibrosis. You can see it goes above the median nerve, above the artery, and you can see the two heads of the biceps, and again gets below the biceps head. So you can see the continuity of the lacetus fibrosis is of utmost importance to look for whether there is any injury to the distal biceps tendon. So it actually gives a lot of value if you actually look at the lacetus fibrosis. Brachialis is actually has two heads which is actually blended just above the trochlear cartilage, and it attaches to the coronoid process of the ulna. There is some condition which is not very common here. You can see just below the biceps muscle, actually. You can see between the biceps muscle and the radius, you can see the small fluid filled cavity, which is the bicipito-radial bursa. And one very important thing, if at all there is an effusion of the elbow, you can see fluid-filled anterior recess, which is there just below the fat pad there. This is the fat pad below the biceps. You can see there is an anterior recess, which will be fluid-filled. And this is how it looks like. The anterior joint recess, very, very rare to get such effusions there. So this is the effusion, post-traumatic effusion in a patient who actually had a flexion injury. Joint effusions are common in overuse syndromes, arthritis, infection, gout, or trauma. Unless you know what exactly you are actually seeing, if there is a proper history which suggests you that this is the particular condition, do not put in a needle just for the sake of draining an effusion or putting in a steroid. So the key points, the distal biceps tendon, the laceta's fibrosis, brachialis muscle and the tendon, bicipitoradial bursa, median nerve, and the effusion. So these are very, very important things which we need to understand about the distal biceps tendon. Now there is something called the lateral elbow pain, the most common being the lateral epicondylitis or an epicondylopathy, lateral ulnar collateral ligament injury, pin entrapment, posterior interosseous nerve entrapment, radial nerve injuries, or a radiocapitellar joint arthritis. So these are the common ones which actually produces a lateral elbow pain. So we actually look for the commonest one. Common extensor tendon is formed by these four tendons, ECRB, EDC, EDM, and the ECU. Why we need to know all these individual tendons is because you can actually see on the short axis view of the common extensor tendon. This is the anconeus, the ECU, extensor carpi ulnaris, EDM, that is the extensor digiti minimi, and you can see this is the ECRB, which is the by far the biggest tendon, right? So all these structures which we need to identify when we look for the axial view of the tendon. So you can identify where exactly the tendinopathy or the tear lies by looking at the short axis view of the tendon. The lateral elbow pain, there is a functional impairment mechanism, repeated microtrauma happens because of repeated microtrauma in job related activities, sports and daily activities. There could be a problem with, there could be a painful supination of the forearm and the dorsiflexion of the wrist. So clinically you diagnose it and you can actually identify and stage the pathology by ultrasonography. And also you can understand the type of actually like changes, the tendon changes, whether it is a chronic change, if there is a calcification. Sometimes there could be an increased neoangiogenesis, which actually suggests that it is a acute or a subacute condition. So you can actually do a sonoelastography also, trying to find out how much is the tensile strength of the common extensor tendon. So there are so many things which you can actually make out by ultrasonography. You can basically stage the disease and you can decide if there is a chronicity of that. So there is a calcification, what to do, and if there is an acute thing, can you actually add a steroid for the injection, right? So this is how exactly it looks like pathologically. There is a heterogenic tendon, there are hypoechogenic areas and there are hyperechoic areas. You can see the cortical irregularity and the stippling of calcification there. And you can see sometimes a tear, which is a slightly extended tear. There could be a enthesopathy. You can see that there is a enthesopathy. So all these are common changes. See, small tears, the micro tears, which is occurring because of the repeated friction, activity related friction. So there will be a lot of micro tears, which actually needs a intervention by regenerative therapy. Right. So what are all the differential diagnoses here? There could be a lateral collateral ligament tear, which is probably better off with an MRI. If you are diagnosing with an ultrasound, probably you might actually miss pin entrapment and soft tissue masses. So all these are potential differential diagnoses for a lateral elbow pain. And you should also rule out tears. It could be partial, complete, acute, or a chronic. If it is a complete tear, it's going to be surgical. If it is a acute tear, again, you can actually treat with either a steroid or a PRP. All the non-operative methods must be tried prior to an intervention. Give adequate rest, activity modification, physical therapy, NSAIDs, steroids, and lastly, PRP or an autologous whole blood can be given. Orthotic devices with or without intervention, orthotic devices plays a significant role. So needle fenestration, steroid and PRP, this is a patient who is 32-year-old, who is actually an ultrasonographer actually. Means like because of this particular calcification, she keeps on scanning on the same side actually. and there is a small little calcific chunk there. So we could do a proper fenestration of the calcific chunk and deposit the PRP into the substance of the tendon. So any PRP injections must be given into the substance of the tendon. The entire concavity of this side actually is the tendon. So anywhere actually you can do a fenestration, create a new inflammatory focus there, create new angiogenesis, and then you infiltrate your PRP, freshly prepared PRP there, right? And yes, this is how you do a proper needle fenestration there. And repeated passes, at least 5 to 10 passes with your 23 gauge spinal needle or a 23 gauge, so 1.5 inches needle actually. Go into the substance of the tendon repeatedly, create some amount of inflammation, and then go ahead with your PRP injection into the tendon substance. So if at all, if you are going to give it into the tendon, the steroid into the tendon with or without ultrasound guidance, this is what can happen. You can see there is a partial tear within the substance of the tendon, which is going to cause repeated friction, more pain, and more substance tear possible if it is going to be given inadvertently into the tendon substance. So what are the key points? The most common disorder of the elbow is the lateral epicondyal pain. The diagnosis is lateral epicondylitis or a pin syndrome. The lateral collateral ligament, better to do an MRI before you actually make a diagnosis. So radial nerve, actually, I'm not going into the depth of it. Let us see what exactly is pin entrapment. Actually, all of us know that there are some 7 causes. Theoretically, there are some 7 causes why
कर
there could
सकते
be
हैं
a way.
मुस्तफा था क्या हाँ सो इतना कंप्लीट करने के पीछे पड़ो इतना महत्व का है सो ये सीखिए
Others,
Dr.
please
Khalil,
mute
can
your
you?
audio, please.
Yeah,
सॉरी सर सॉरी
yeah, please. Okay, thank you. Right. So if there is a pin entrapment, where all it can happen, there are some theoretically some 7 places where it can get entrapped. And out of which the arcade of Prose is the most common one, which is the compression at the proximal edge of the supinator. There is a loss of the fascicular pattern and hyperemia and thickening on ultrasonography. You can see there is a supinator there. That's a radius supinator, the superficial and the deep edge. And that's the intermediary layer. That is the monofascicular posterior interosseous nerve on its short axis and the long axis. And this is the one which I'm trying to do a uh, hydrodissection with 5% dextrose, right? And you can do a 5% dextrose hydrodissection like this. Right. Now, there is an interesting patient actually whom I wanted to discuss here. This is a, differential diagnosis for a inconclusive tennis elbow. And there are no standard values basically, like it's a monofascicular nerve. So there are no standard values for nerve thickening. You can do a transverse and axial scanning and you can find out whether there is any dilatation of the monofascicle. You examine both the entry and the exit points. And one very important thing all of us must understand is these patients are prone to develop finger drop and they don't develop a wrist drop. If it is a wrist drop, it's a proximal injury, likely to be a radial nerve. And if it is a finger drop, it is more likely to be a pin entrapment. So this is a patient who had a Galeazzi fracture for which an implant was done 3 days back and for which a plating was done and there was a supinator there, and there was a close by posterior interosseous nerve which was getting entrapped with a screw, right? This is how it looks like. The patient does not have a wrist drop, and there is a finger drop, right? See this? And this is some case which we did in 2015. And after which I saw one more patient in 2025. Such a rare thing, but you should always keep in mind that posterior interosseous nerve entrapment is always a possibility in a patient who has undergone a recent surgery and developing a finger drop. So medial epicondylitis, again, quite a lot of overuse which can cause because of valgus stress with repetitive flexion and pronation. somebody who plays baseball, tennis, golf, fencing, and swimming, labor-intensive activities. And in the ultrasound appearance, you can see there are some blood vessels, neoangiogenesis within there, and you can do clinically a valgus stress exam to find out whether there is any uh, uh, common flexor tendon related problem. So there are quite a lot of these differential diagnoses. So there could be an acute, means like occult fracture, soft tissue injuries, effusion, uh, could be a chronic and an acute injury, tendinosis, neuropathies, ulnar neuropathy. All these are differential diagnoses for a medial epicondyle related pain. And you can see very a little bit blood vessels within there because of an acute inflammation, because of a tendinopathy, and you can actually plan for either a steroid or a PRP injection. The common flexor tendon, it's slightly shorter, stouter, and broader than your common extensor tendon. Use the elevator method. Basically, like I always say, like, there is a different type of scanning which you need to do. That itself is a different session. You could do both the long axis and the short axis scanning just inferior to the epicondyle. And this is the short axis scanning. You can see that's the uh, you can see that's the brachialis, and this is the pronator teres, trying to find out, go medially, more medially, and you can see all the muscles, all the tendons which is related to the common flexor tendon. As I showed you on the common extensor tendon, the different parts of the common flexor tendon also must be appreciated. Trying to find out which particular muscle or a tendon which is involved in the common, means like a flexor tendinopathy, right? So apart from that, what other medial structure is, one very important thing is their ulnar nerve, which can get entrapped close to the cubital tunnel. These are prone for injuries because it is very superficial. Compression can occur by the Osborne ligament. Sometimes there could be a snapping triceps, dynamic subluxation, and there could be entrapment between the two heads of the FCU. So how exactly do you look for? You can do both a static and a dynamic examination. There could be a focal thickening. There could be a notch sign. Sometimes there is a compression which is causing a notch-like appearance. And there is a bifid or a trifid nerve sometimes. Okay. So here I have actually done a long axis injection of 5% dextrose here. You could do either a long axis or a short axis. Slightly difficult to do the long axis injection because you might end up doing a false injection either intraneurally or somewhere very, very far away from the nerve. So you can actually very well do a proper injection in the short axis. So this is how it is looking like in the short axis. You can see the medial epicondyle there, and there's the ulnar nerve, and above which you have the Osborne ligament, the ulnar nerve, and below which you have the posterior band of the ulnar collateral ligament. Basically, it actually is pocketed, the ulnar nerve is pocketed between two ligaments there. Just a minute. Yes. So the ulnar nerve is pocketed between the two ligaments there, the posterior band of the UCL and the Osborne ligament. And you can either come from medial side or from the lateral side. And that's how you do the hydrodissection. And very clearly, you must actually avoid the nerve and ensure that you put in some 5% dextrose above and the below the nerve, and hydrodissecting the space between the Osborne ligament and your ulnar nerve. So very clearly, you must actually do a proper hydrodissection at the cubital tunnel, and always choose one more place where you should be doing a hydrodissection, that is between the two heads of the FCU, which I'll show you now. Yeah. So these are the medial ligaments which we are just discussing actually. This is the Osborne ligament there, and this is the posterior band of the ulnar collateral ligament. You can see the flattened ulnar nerve, and this is how it looks like when the patient's elbow is flexed and extended. You can see the differential position of your ulnar nerve, and sometimes it looks compressed on flexing. So you should also be very careful in measuring it. So anything more than 8 millimeters square is considered to be having an entrapment. And these are the two heads of the FCU, and in between you have the ulnar nerve just below the medial epicondyle, right? So there are quite a lot of these lateral ligaments also, the radial collateral ligament, the ulnar insertion of the annular ligament, the lateral ulnar collateral ligament, all these ligaments you should be taking care, particularly this lateral ulnar collateral ligament and the radial collateral ligament, where you can see a small little calcification there. If there is a chronic injury to this ligament, that calcification might probably require a needle fenestration if at all there is an intervention to be done. Otherwise, it is going to give long-term pain in spite of whether you do a steroid or a PRP injection there. So you always look for a small little calcification in this particular place where there is a radial collateral ligament which is bridging there. Right? So the posterior elbow, very important to understand, there is a thick triceps which is getting attached to the olecranon there. And you can see the olecranon bursa, and there is a posterior joint recess, and you can see the lifting up of the posterior fat pad. When there is an effusion, there is a lifting up of the fat pad. And this could be the problem there. There is an effusion there. There is a small little injury. There is an avulsion injury to the triceps. And you can see there is an effusion which is actually lifting up the brachialis muscle. If there is an effusion, you can see the lift up of the brachialis muscle on the anterior axis, short axis and the long axis view both needs to be confirmed. And there is a triceps injury there in this patient actually. So triceps as such, we know that there are three heads, the medial, deep, and the lateral head. And the tendon injuries can occur in steroid use, renal diseases, bursitis, olecranon bursitis, and patients with hyperthyroidism. Injuries can be there because of the direct blow, deceleration force applied to the arm, complete, partial, or avulsion. So all these can be actually made out by ultrasound examination. And this is one very important patient which I actually wanted to discuss. This is a OT technician who actually reported to me with wasting here on the triceps. He basically thought it is a shoulder related problem. So he just immediately reported to me there was a difficulty in lifting, means like doing an abduction. That's what he told me. And exactly there was a lot of wasting on the triceps. You can see there. He's not able to perform the proper extension at all. So this is because of the cervical disc. It is not related to any injury to the triceps, and it is nothing related to the elbow, and it is because of a purely cervical disc, which actually he had to undergo a discectomy and a proper rehabilitation, right? And there is one more patient actually who actually had a ACL tear, who was on a crutches, and he fell down when he had his crutches, and this is how the limb attitude looked like. So you can see the patient says that the immediate complaint the patient reported to was, I'm not able to straighten my elbow. So this is how it looks like. So we try to look for whether there is any problem with the elbow. This is how exactly it looked like. There is a triceps tear and there is an effusion here. Posterior olecranon recess means effusion. I deferred doing any intervention here. I just gave a course of NSAIDs for 1 week and a lot of ice pack, and that was good enough for the triceps tear, followed by rehabilitation. And there could be a subcutaneous bursitis because of the olecranon bursitis related to infection, trauma, inflammatory arthropathy, and it would be septic, sometimes related to infection. Always very, very clear, very important to understand. Elbow is one area where you should have at least 10 times to think about if at all you are going to put in a needle into the actual joint space. And olecranon recess, you can actually find out if there is an arthritis, loose bodies. You could see some fat means like means like upward pushing of the fat pad. The fat pad sign effusion enhances the visualization of this fat pad. So all these actually needs to be understood before you actually going for treatment of these patients. So very rarely, very, very rarely, you should put in a needle into the joint space. The most common being the lateral epicondylitis, the next common being your distal biceps and your medial epicondylitis. So these are the common things. Other things you need to know, but very, very cautious about your intervention. So the diagnostic value of ultrasound, very, very important, particularly with related to examination of the elbow. Correlate it clinically. Whatever the patient had clinically, try to correlate it and then understand that arrive at your decision only based on your ultrasound and your clinical examination. A lot of times, even ultrasound does not give you any proper value. Go for your MRI before you treat. You could follow me on Facebook, Instagram, and my YouTube channel. Thank you.
Thank you, sir, for the wonderful
Yeah, and
lecture, and it's
and and
self-explanatory. Yeah.
yeah, specifically, I have used only the patients which I have come across. I have not taken it from my textbook because these are the ones which you actually come across in your clinical practice.
Thank you, sir. We have with us Dr. Chinmay, Dr.
Yes,
Shovan.
sir. Yes, sir.
Any question, any query?
Nobody wants to ask questions. People are there.
Sir, they are there, sir. They will be asking. Samriddhi Dubey is asking, sir, how much volume to inject for hydrodissection?
See, hydrodissection does not carry any specific volume. I always say, like any neural hydrodissection for posterior interosseous nerve entrapment or for your ulnar nerve, you should ensure that the needle actually gets a proper release of the nerve from the adjacent tissues, nothing else. It could be 3 ml, it could be 5 ml also.
Anything else? Any other doubt?
I think people are happy about this actually. Like a lot of people, most likely know, like we don't get into diagnosing. It's not like a shoulder or knee or anything like that. It's a very uncommon thing which people do an ultrasound for. Elbow is an area where everybody has to know that this is also very common. This is also very common. You need to make a diagnosis, and probably a lot of times you might actually require an MRI also. And before an intervention, like please don't do means like have a diagnosis on hand. Don't do any diagnostic interventions. It's not like your shoulder where you can do a subacromial bursa injection, maybe to diagnose a tendinopathy or a impingement or anything. But elbow is some area like we'll have to be very cautious about. And more importantly, intra-articular joint injections, very rarely you should use. You should never use rather, I'll say.
So just one thing to ask. Suppose I have to make this diagnosis in corporate world where we are working.
Yes, sir.
Most of people they want. I don't know whether they doubt our clinical thing or they are not very sure about. But they want to be very sure before diagnosis. They want some sort of diagnosis by either ultrasound or MRI. So, we as a pain physician, we are not using it just for diagnosis. We either, if I am taking a patient to my OT, if I will diagnose, I will do diagnostic, whatever, I will do something. And secondly, as such, I cannot give a written means summary of whatever we have found for others to use. So if I'm asking my ultrasonologist to comment on them, do we expect all these comments from them?
Sir, I'll tell you. Uh, Ultrasound on an interventional pain physician's perspective is different from what a radiologist is seeing.
Yes, sir.
Say, for example, you send for an MRI, right? And they say that okay, this is a distal biceps tendon injury. You basically are planning to do a proper intervention with a PRP, right? So how are you going to do a PRP injection unless you know how to do a scanning of the DVT? So basically, if it is only for making a diagnosis of distal biceps tendinopathy, if I'm very sure, I think like we don't need to. But even today, radiologists say like you have to. But why do we study so extensively if we cannot actually make a diagnosis? Right. So if at all you have a doubtful diagnosis, then definitely an MRI is required, be it whatever part which you are scanning. Definitely it is required. Sometimes you basically will be seeing just an effusion which needs to be just drained, nothing else. For which, why do we need an MRI? So
Sir.
that way, if you look at all the imaging modalities, be it CT, MRI, or your ultrasound, All these are interpreted by human beings. So you might interpret it differently, I might interpret it differently. That's all. The whole thing is just because a radiologist has interpreted an MRI, it is not the gold standard.
True, sir.
So I feel so. But see, whatever I have shown here, the entire thing, I have done MRI in only one patient. Whatever images which I have shown, that is only for that OT technician who had a radicular pain, and that is because of the disc disease he is having actually that weakness. So that is a red flag where you require an MRI, without which you can't do anything. And very clearly in patients with trauma, patients with cervical disc disease, which is actually mimicking as a elbow related disease. So those are the patients which we require an MRI. Otherwise, we don't really require.
True, sir. True, sir. Sir, Preetham, we want to know needle gauge for fenestration and extent of fenestration and volume of PRP.
Volume of PRP actually around 3 to 4 ml is good enough, sir. But fenestration you can do with a 22 or a 23 gauge needle, be it a spinal needle or your 1.5 inches needle. Generally, I prefer to use a black one, black needle that 1.5 inches. That's all. So it gives good fenestration. Not just see, if you use a thinner needle, it gives comfort. The initial pain won't be there, but it does not serve the purpose. So you need to do a proper fenestration, which opens up new channels for the vascularization. That's the reason why we do a fenestration. Slightly bigger needle is not a problem. Don't use very thin needle. And more importantly, while injection of PRP, it is always better to have a slightly 23 or a 22 gauge needle rather than a 26 needle.
Sir, thank you. Actually, the lecture was so much self-explanatory with so many pictures of your own. I think students have got the message. That's why the doubts are uh,
No,
comparatively less.
actually, I don't have any material from the books, sir. Books does not say anything beyond this. So basically,
Sir,
like what we have, I think like 2, 3 good people coming around with a lot of material. No, that is more informative than the books itself.
true, sir. True. So, if there is no other question, can we call for the day?
Yes, sir. Sure.
Okay, sir. Thank you so much,
Okay.
sir.
Thank you.
Thank you, IPM, for organizing all this. Thanks to all the students for joining in. Thanks a lot. Good night, sir. Good night,
Right, sir.
everyone.
Good night. Good
Good
night.
night. Thanks.
Bye.